Thank you very much indeed for the invitation to participate. And it's a real, I don't say this lightly, it's a real honour to be invited to talk with a group of patients. I think the normal context people see doctors in is that kind of how you organise your room is still adversarial. It's still one person in a position of knowledge and one person in a position of needing help. And you can try and break down the barriers, but actually the chance to do this in a kind of hopefully informal way once I get off this podium is the part that appeals to me most. I take incredibly seriously the opportunity that I have this morning because I think this is actually an unbelievably good time to do what I do. I am not a proper gastroenterologist. I was actually a nerve doctor who became a bowel doctor by accident, and I became that because I felt when I was a nerve doctor there's nothing I could do to help patients. At the time, 25 years ago, we made clever diagnoses and then said bye-bye to people and wished them well. And I went into gastroenterology because at that time I was excited by being able to put tubes into people. And that was fun when you were young. And what I rapidly realized is that the tube part of it is the kind of the headline. What is interesting is people had unbelievably rich stories. And what I am actually is a very nosy person. And research is about being nosy. And what's been brilliant about what's transforming this area of medicine is the fact that for the first time, we're moving away from thinking about patients as the victim of our treatments. And I think that sounds patronizing to say, but the problem has been that because we haven't had proper so-called biomarkers, we haven't had proper measurements we can make for people with functional disorders. And I will differ with Adam, well, I think Adam's going to say, I don't think we'll ever get these markers. I think we've got to forget about finding these things because all of us are individual. It's a bit like saying what makes you different to you, to you, to you, to me. There are countless things. It isn't just my genes, it isn't just my experience, it isn't just that I'm bald, it isn't just that I wear glasses, it isn't that it's any number of things and all of those things at any one time. So will there ever be a marker that helps us identify the condition? Not a bloomin' chance, in my opinion. Happy to be proven wrong over the years. But that doesn't mean we can't make innovations. And what's fantastic is that most of the innovations being made are around patient-centered therapies rather than us saying to you, you have X, I've proven this by doing Y, therefore I'm going to give you Z, and you're going to be better or you're mad. And that's what's exciting. So, with that in mind, you can see how much stock equity I hold. I think it begins with this, and I've sort of alluded to this already. When I see a doctor, and I see plenty of doctors, I want them to tell me what's wrong with me, number one, and I want them to tell me what they're going to do to make me better, much more importantly. And the problem is that as soon as we use the word functional, which of course we are all sitting here with that in mind, it becomes a completely different thing. Functional, by definition, means that there's nothing wrong with your organs. Your organs look fine, it's just that they are not functioning correctly. And functional to most doctors still means it's not real, because we are trained to believe that this is here, and anything which isn't there to see or to feel is not real. We are all intrinsically doubting Thomases in medicine. That's how we're trained, and we're trained serially to continue that myth. And so saying somebody has a functional problem, by and large means that the doctor says it's not real. And when something isn't real, you say, well, I can't have a biomarker, like I've just said. If it's not real and there's no marker to identify it, you know, there's nothing you can do about it. And so patients end up being labeled as having chronic functional disorders, which is an even bigger sin. Because not only do you have something which isn't real in theory, you suddenly have something in theory which is going to be there forever. And is there a worse thing to hear than there's nothing really wrong with you and you're going to have it forever? I mean, it's unimaginable. I mean, it's the worst of two possible sort of black holes. And that sense of nothing I can do to help you, nothing really wrong with you, inevitably leads to alienation. And that's the problem. It then comes full circle to say, well, you've had this for so long, we're never going to be able to help you, therefore it's functional. And it is kind of Kafka-esque in that sense of you get nowhere because you can't go anywhere. And what this results in, of course, and I say this as a sufferer as much as a doctor, is that if one person doesn't help you, you go and find somebody else who does try to help you. And eventually you may luck out and land up on Yan's doorstep, but more often you'll end up on somebody else's doorstep who says, yes, 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 that's all very well. And they may hold your hand a bit warmer for a while, but then nothing really usefully happens. And so you have this eternal cycle of people shopping around and doctors then allocating blame to the patients, saying, well, you see, they've gone to 15 different doctors, they're going to be tricky patients. So this is a self-fulfilling nightmare. Thus far, thus miserable, okay? So what am I optimistic about? Because actually, what's suddenly transformative is we can build on it. Rather than saying, oh, well, that's just a difficult patient group we will never help, what we're now saying is that actually that opportunity allows us to tailor treatments for individuals. So the big mistake that our regulatory authorities make is they say that we need a treatment which covers everyone. Because you're all the same. I look at all of you and you all look exactly the same to me. Well, of course you don't. And so what we're now beginning to see is hopefully that beginning of the process whereby we'll say to people, with your kind of thing, we'll accept that only 15% of you will get better and 85% of you may be exposed to the treatment and get no benefit at all. But you will do well with this, which none of you will do well with. And that is beginning to creep into consciousness of doctors. Once doctors get it, then the so-called regulatory authorities and people who fund research and fund treatments will get the message, I promise you. So what are we talking about? We're talking about pain. For me, IBS is a pain condition. Yes, it may manifest with bowel dysfunction, but it's about pain. Because I see in my neuro clinics, which I still run, patients who have pain in their head and they get chronic head pain and they're labeled as chronic functional headaches or chronic functional migraine. I see people with pelvic pain. I see people with chronic back pains in my neuro clinics. They're all, it's a pain syndrome. And some of you who have these IBS symptoms also have symptoms elsewhere. So this is about a pain phenomenon and a chronic feeling of having pain, which may manifest as the light flashing in different bits of your body. So that's for me the first thing. This is a pain syndrome. And what causes pain? Well, you see, this is what happens then. So clever doctors, mostly American, sit and come up with figures like this which say this explains it all. So here's these 15, 25 different things which explain the condition. And there can never be a condition which can be explained. There's no illness which can have this many causes. So therefore we say, oh, it isn't a real illness. It feeds into that same thing of not being real. But actually there's a much better way of looking at this. And this is where the neurologist comes into this. What makes people have pain? Why do I get pain? Why do I get pain? I get pain because I bang my hand in the door. That hurts right now. But why does that hurt all the time if I haven't banged my hand in the door? Well, it's one of three things that happen. One is that there's too much sensation coming from here, which we call afferent excitation on that far left of the triangle. The second thing, which is in the middle of that space and not really labeled, is that once we get pain all the time, we begin to know it's going to hurt. So we begin to be vigilant to that area, and that's how we protect ourselves from having further pain. But unfortunately, that makes things worse, because once we're vigilant to it, you think, oh, is that hurting or is it not hurting? I don't really know, but it's not comfortable. And then remember this, that the first thing they teach us in neurology school is this, that most of the time our brains are switching our body off. Because if we had to live every second of our life by thinking, my pupil is this big, my bladder is this full, my stomach is this empty, my hair is this long, or not, my, everything, my hands are here, we can't live with that. It's information coming to our brain, but we process it out because we disinhibit. This bit inhibits what's happening here. And sometimes we lose that disinhibition. And if we then think about that scheme of things, where we go from too much sensation here to our brains being vigilant to things, to our brains not switching off messages, we then begin to see how those multiple mechanisms can begin to play a part in our symptoms. And that leads finally to where we can begin to look at treatments. So what are these treatments that are out there? The first thing, which you've already heard alluded to, and most of you will know about this, I'll keep it very, very brief, is the notion of dietary therapies. And again, for years, doctors have said, well, there's no real diet for IBS, go and look after yourself. Or we've said, I strongly believe in this diet, I strongly believe in that diet. And you've either had a complete lack of interest or over-interest and assuming that one diet suits all, which again can't be. And what's becoming clear is that there is a diet which helps some people. And the low FODMAPs diet helps people, in my experience, primarily who have bloating and diarrhea. And why does it do that? It does that because you cut out these foodstuffs, forget what they're called in scientific terms, but the foodstuffs have two effects. So we've listened to patients at last, and patients said, I get noisy, bloated stomachs, and I I pass wind and it gets easy. And say, well, it can't possibly be getting easier if you pass wind. You pass 30 mils of wind, how can your tummy get less bloated? You're bonkers. But actually, you know what's happening? What's happening is some of these foodstuffs are capable of making our guts ferment differently, and some of these foodstuffs are able to hold on to water, which is what osmosis means. And when you reduce the amount of water being held and the amount of fermentation that occurs, you can reduce the things that happen in your guts. So it doesn't help everyone, but people who have problems with bloating and diarrhea in particular seem to have a particularly good response to this diet. Not everyone, but it's out there. And there's now tons of data supporting this, and there's apps out there. What else can we do as patients apart from change our diet? We can be really doing things with probiotics. But the problem is, at the moment, and this is the most negative message I'm going to give you, is that the science can't help you. Your individual gut bacterial profile differs as much as your fingerprints for all of you in this room. So there cannot be a single probiotic which again will help all of you. But once some clever doctors and scientists around the world get to know that the genome, the genetic makeup of your particular bacteria, then you have progress. This is a fantastic summary written for the scientific profession about the probiotic research we have to date. And what it tells you is that these drugs undoubtedly have value, but I can't sit into you and say at the moment it's this or that. So if you can afford a probiotic and it helps you, great. But can a doctor tell you what to do just yet? No. But if there's a center which you're working with which has a research facility doing research in this, please get involved, because this is rich. This is a rich, rich area. This is the biggest coal mine in terms of potential drugs of all the areas I'll talk about. This is gold dust for tomorrow. Coal, gold, I'm not sure what I'm talking about here. Now, what else do we learn about patients with constipation? We learn the following things. We learn that if we ask patients, they tell us what they want. But this data has really poor scientific value. People look at this, my colleagues, if I was presenting to a scientific group now, this is the point where they'd roll their eyes and say, here he's off on one again. But actually this is data generated by industry about what patients want from a laxative. So if you can't open your bowels regularly, what do you want from your drug therapy? And what it tells us is that there's, broadly speaking, although there's kind of 5 big headlines, there's broadly speaking 2 big areas that patients say they'd like. And you can again confirm or refute this to me. The first area is you want it to be timely. So if you take something, you want it to work now and stop working now. You don't want it to start working maybe 3 hours after you've taken it when you're on the school run. You don't want it to work for 15 hours of the day so that you're running back and forth to the loo. You want it to be predictable. And that's what laxatives generally are not, unfortunately. The second thing it tells us is that we want it, and it sounds obvious in some ways, not to give us any other symptoms. So if your problem is to do with not going to the loo, you don't want to take a drug which then gives you cramps. If your problem is to do with bloating, you don't want to give you a drug which then makes you have terrible diarrhea. We don't want to symptom swap. And this is kind of obvious, but has that made any difference to our treatment historically? No, we've just generated more and more laxatives of the same class. Yes, we've got this, so we're going to make Movicol 1, we make Movicol 2, we make Movicol version 3, we've got Senna 1, Senna 2. It's the same, we haven't really used that information historically to change things, but that can change. That can change because the clever science now helps us understand what happens to people whose bowels don't work properly. This is a really beautiful illustration of what happens to those of you who suffer with very infrequent bowel movements. This shows a healthy person. This shows somebody over a 24-hour period from 2 o'clock one day to 2 o'clock the next day with a lot of a probe, I'm afraid, in your bottom, which measures pressures from the top of your colon over in the right-hand side here, all the way down to the bottom end, down to the anus. And it shows that through the day, you get these little green hills of activity. These are nice big pressures. These are like big waves you see if you're a surfer, which bring a nice lot of content down from that right side of your tummy down to the left-hand side, or sometimes all the way out. And you get these clusters of contractions after you've had lunch, dinner, and when you wake up. So that's why our bowels, if we're lucky, tend to work at those times. So this is what happens to a healthy person. It's not difficult to see what happens to a patient. It's so different. They get no green hills. Okay, there's no activity there. There's almost nothing. So they don't get the urge to, they don't get any of these big waves bringing things down. They get lots of red stuff, which is these backward contractions, retrograde contractions. So stuff actually goes backwards away from their bottom rather than forwards towards emptying. And once we see that, that then gives us a signal of what we can do. So this doesn't mean that every one of you with constipation has this problem, far from it. But once we have something, the biomarkers are helpful, if they exist, to help us identify a treatment. They're not helpful for us being able to say, this will work for you or you, unfortunately. And so that's led to new drugs. And lots of these new drugs work quite differently. You see, and this is kind of animation I'm very proud of, so permit me while I play through. We take them orally. Oh, blimey, so I've fallen. We take them orally. What is this going to do? So, very good. And laxatives, as you can see, they go into your stomach, they work their way through your stomach after about an hour and a half, they leave your stomach, and then they work their way into your colon. And they take a long time in green to trundle down there. But these newer agents, interestingly, work by going straight to your liver very quickly, and then from the liver, via the bloodstream, which is much quicker, go to your organ of interest, namely the colon. So they get down to the colon terribly quickly, within half an hour of taking them usually, in terms of having an effect, whereas your little laxative is still trundling its way down there now, before it finally gets there anything between 10 or 40 hours later, which is why it's unpredictable. So these new agents have responded to what patients have asked for, predictability. I want to take it now, to work now, and stop working now. And this is one of the ways in which they can work. So there is progress. There are agents in development which are doing this, and there are agents out there now which already do this. What else is there? This is a lovely story. This is a lovely, lovely story. So there's a very nice Catalan microbiologist from Barcelona, near Barcelona, whose wife suffered with lifelong constipation. And about Christmas in 2000, she got a terrible bout of E. coli, and for the first time in her life had diarrhea. And she was delighted, apparently. She was so happy. And this very inventive microbiologist decided to look at why this could be the case. Why did his wife, who suffered constipation, how could he use this therapeutically? And recognized that E. coli produces a poison called a toxin, which stimulates a very particular receptor in your gut, which, unfortunately, when it stimulates it, causes it to secrete this compound called chloride into your gut all the time. Well, that's no good, because it just keeps going and keeps going until your body eventually clears it. We can't be giving people E. coli with every dose of drug we take. But he devised a mechanism where we can stimulate that same receptor with this drug called lactatide, which then gets knocked off. So once it's bound to the receptor, it doesn't stay bound like the poison, like the E. coli poison. Once there's enough chloride in the gut, it literally elbows it out of the way, so it then gets destroyed and removed. Why is this interesting? It's interesting because it's a patient narrative resulting in therapy within 5-10 years, but it's interesting also because it is a drug which doesn't, the other one works predictably, this works only in the gut. The only side effect of this drug is that it causes diarrhea if it works too much. So it doesn't get absorbed. We measure it in your bloodstream, we see almost none of it. So this is an inventive area, and these drugs may not be the solution for all of you in this room by any means, but what they are is a hallmark of a new way of approaching drugs. Rather than saying, here's another laxative, here's another painkiller, here's another morphine-like drug, here are inventive ways people are using the science to go forward. So I don't necessarily think that you're going to find the solution for all of you, but some of you will find help with some of these drugs. But the door is opening, and the door is opening in terms of drugs, but the door is opening in terms of how doctors think about the drugs, and most importantly, how your funding authorities will help fund these drugs in the time to come. And there's other drugs. This is another drug called lubiprostone. Again, works in a very similar mechanism to the last drug I showed you, but it's out there, it's very much licensed in the US, and it's going to come here at some point soon. It's in the process of being looked at by NICE in a very favorable way by the look of things. It's already approved by the Food and Drug Authority, which you may know is the equivalent of the authority in the USA, and it's getting use. And there are other drugs which can block the effect of morphine in the gut. So there are drugs which affect when morphine can block your gut, and we can reverse that. So morphine slows your bowel down, makes you vomit. Taking some of these drugs which antagonize, which block that effect of morphine, can make that better in patients who've taken morphine, but even seemingly in some patients who haven't taken morphine. What else is there? There are other drugs we can target the microbiome with probiotics, I mentioned, but you can also target it possibly with antibiotics. Now, I don't necessarily believe in this, so I must declare a prejudice and an interest. I don't think this drug is working or can work realistically. This is a drug which is an antibiotic which kills bacteria in the gut, but it's blooming expensive. I don't think any health service in the world can afford to spend £500 for a fortnight's treatment for a drug which you may need to repeat 2, 3, 4 times a year. It's an antibiotic. Do we want to be using antibiotics 3, 4 times a year in otherwise healthy people? I don't know. So I have qualms about this, but again, it's a way of approaching things, looking at the probiotic story in a different way, and that's exciting. So none of these necessarily are going to be the solution for each one of us, but they are open opportunities. And this is a condition I love treating. I was taught by many, many great men, one of whom was a man called John Leonard-Jones, who's my hero. And LJ said to us, never do a talk where you may get a referral. And I actually think that's wrong, because I think bloating is a really, speaking to somebody who has a child who has terrible functional abdominal bloating, it's an enormously intrusive symptom. You know this better than I do from secondhand experience. And actually bloating is different to many people. This is not the kind of fatness. You can see this feature here, this is a clinical sign where the ribs are sucked in. There's a recession of the ribs. So this isn't somebody pushing their tummy out. This isn't just fatness or weight or fluid. This is a physical sign. And about a quarter of the patients I get referred with bloating have this feature. This is a real entity. And we can do something about this. It's just beginning. Not for everyone, as I keep saying, but for some people. What we recognize is that it's not just about the amount of gas in your tummy. Some brilliant clinical science, doctors doing science back to Barcelona again, have developed the idea that actually it's not about how much gas there is in your tummy, but how your bowel handles that gas. And where a neurologist gets excited about this, it's when all of us eat, our tummy wall becomes stiffer. So when we wake up in the morning, our tummy wall is tight, like this. And as the day goes by, it stays at that tension, especially after eating. It gets even tighter because as the blood goes to your gut when you've eaten, and about a quarter of your blood goes into your gut when you eat, it knits even tighter. And what they found, there's lots of scientific stuff on here, is that these muscles in your tummy wall in people with bloating get slacker. So rather than getting tighter, it gets slacker. So all this stuff that's gone into your belly, the food and the drink, plus the blood flow, suddenly pushes against a soft wall rather than a hard wall. So your tummy bloats out and you get that sucking in of the ribs up here and the protuberance here, which is worse at the end of the day and after meals. And that's all very well. We understand the science, but the science has now led to therapies. We can now do a version of biofeedback, which you'll hear about again in the next 2 or 3 minutes I've got, where we can try and train people to understand and to use visual biofeedback. What is biofeedback? Biofeedback is making you conscious of the things that you can't necessarily feel. I believe this is a very helpful therapy for some people. The analogy I use is like playing the piano or musical instrument. If you can't hear the notes, you don't know if you're playing it right. And what biofeedback does is allows you to become conscious and to hear those notes. And once you can hear them, think, oh, that's not right, I'll play it again. That's it, I've got it now. And then you keep playing it again and again and again, and that repetition becomes the new habit. And we can do that using the diaphragmatic contractions to make people conscious and make increased abdominal tension in their abdominal wall. That's enormously complicated to try and explain, and I hope I've probably baffled or surprised you, but there is a potential mileage in this, in trying to make people conscious of how their diaphragm works and make the tummy muscles stronger. I am a strong believer, and I think it is fantastically rich, and I know you all have your own stories hearing the first presentation from a patient perspective. I see so many patients who are terrified of toilets. There are patients, and you have this extraordinary dichotomy of wanting desperately to find toilets, to map toilets on your journey, but equally then being terrified of the things. Because some of us were bullied in toilets when we were younger, some of us are worried about the smells, some of us are worried about the noise that we may make, some of us are worried about somebody coming out and seeing somebody we know, some of us are worried about having to hover over it. We have all sorts of reasons. And I got involved, I'm delighted to say, with an interesting group called the National Phobic Society. And they're amazing. I mean, this country is amazing, what potentially we can tap into. And they got interested, I managed to persuade them to get interested in toilet phobia. And we produced a little leaflet, and I think it's an incredibly rich thing. This is really directed more towards your doctors than to the patients. All of you know what to do. But the National Phobic Society produces this leaflet, which I think is a really helpful thing in terms of helping people to desensitize around toilet phobia. So this is an entity which, again, is it research? Yes, it is, because it's making doctors practice differently. And that's what the definition of research to me is. It's making practice different. It doesn't have to be test tubes and clever scientists with Einstein hair. It's about making practice different. You've heard the kind of service Yan provides in terms of providing a mixture of range of therapies. There's drug therapies, there's talking therapies, there's relaxation therapies, there's language therapies. Do they work? By heck they work. They work because patients tell us they work, and that's the most important proof. But I can stand up in scientific meetings and show slides like this, which actually is a combination of 5 different studies, but I'm putting them into one slide because sometimes patients almost need to be proven. I feel that I see patients sometimes say, I know it's mostly in my head, doc, but that really helped me. I say, it's not. It may or may not be in your head, but I can show you objective evidence. I can show you proof that hypnotherapy or mindfulness training or cognitive behavioral therapy, I can show you that it works. I can show you if you wanted it. And I think it's really helpful that we have this proof for doctors, but actually that we have it for patients too sometimes, so that patients don't leave the room thinking, well, it's just me being a bit funny and I had a bit of attention, so I feel better. It's not that. There is so much more to these therapies, which is based on actually changing how your body works, how the nervous system between your brain and your gut works, how the nervous system in your gut works. So proving that these therapies work is a really important part of it. It may seem blooming obvious to some of you who benefited from this, but there's a real merit in this, because again, it comes back to how we get these services out. What you've heard about the service Yan provides is fantastic, and Yan and the team provide, should I say, but it's not replicable all over this country, unfortunately, because not every authority, not every CEO is as insightful and forward-thinking as what you have locally in the Northeast here. Most places may want to set this up, but they aren't able to because it's not fundable. And this is the kind of evidence we need to make it fundable. So if I can make an appeal here, what a cheek, I'm here talking to patients and trying to persuade you to be interested. I'm now asking you to do us a favor. You know, when you see your GP, don't just tell them about the suffering that you have. Make sure that they understand this is a widespread thing which they need to think about beyond just thinking about cancer and heart disease and those trendy things. This is a group of patients who are left twisting in the wind. And it's not just an individual story of yours. You can look around and see how many of you there are, and this is a tip of the massive iceberg. The final things I was going to say is that we can stimulate nerves. We can stimulate nerves in all sorts of ways. We can stimulate nerves by implants. We can stimulate nerves by big surgeries. We can stimulate nerves by temporary things. Very, very simple things that we can do, and very complicated things we can do, and they can help. We can make the bowel work faster or slower according to how we stimulate. Lots of lovely proof of that. The point I wanted to get at is that there's many, many ways of going out there. And as well as the electrics, that's the electrics, there's also the plumbing. You know, the bowel is a tube. It's a tube which gets stuff which is clean in here and dirty out here. It's like a washing machine in reverse. And we can sometimes fix the plumbing to get stuff out better. And there are seemingly very simple, very logical devices like this, there's coloplast in the back of the area, which have created a system where you can irrigate your bowel out for some patients, and there are newer systems coming along. There's 2 or 3 systems in the UK available to us now. Exciting, exciting areas of therapy. So, in conclusion, for me, the future is enormously bright. The future is enormously bright because we're not going to be having necessarily drugs to treat IBS. I don't know that I really believe in syndromes, if I really out myself. What I believe in is that each of us individually have a particular story to tell, a narrative of how we got there, according to what our symptoms are, what our beliefs are, what therapies we're prepared to accept, and that will elicit in a consultation, and then we can do selective therapies, whether it's electrics, or plumbing, or drugs, or diet, or probiotic, to then individually tailor it for the individual. That's where the future is in functional disorders. Thank you very much for forbearance with me. Thank you.